is set is guided by a set of geometrical principles, and is easy if we follow these principles rigidly. It requires a little more mathematical mind than is required for a science student, biology student. But I think that we can manage if we show some interest. But a simple miscalculation leads to a more profound deformity. So, be careful. I'm showing you a simple example. A boy came with a right femoral deformity like this, and the calculations were done by him, and a fixator was put on him. With this X-ray, I can say that the person, whoever has done this, is not having a knowledge of how to put even a shank pin. He tried to operate on this boy of about 4 or 5 years, and then he has given increased his deformity, and the fixator is not sufficient to hold the fragments in position while in distraction, and at the end, that is the deformity which was exaggerated. And when the patient came with this much deformity, we have given him this type of deformity, additional deformity. So, unless you are trained properly, don't go for the deformity correction. This is my advice at the outset. And at present, I am dealing with one segment deformity so that it has been simplified so that you can understand the things well and then start doing the simple deformities initially, not going for the complex deformities. If I tell the whole thing of mechanical axis, deviation and all these things, you will be confused. So go and read in any book. Recently, Dr. Prakash has sent Dreyer Pelle's deformity correction in 4 volumes to most of the people, and you can go through. It is a very much pictorial. Most of it is diagrams. Just you see and understand. That's all. Not very less of text, and most of it is diagram. You can just go through and you can see the calculation of mechanical axis deviation. Now I am putting you for correction of a single bone with minimal deformity so that you all will start practicing this. I'll give some simple definitions. That is cora. It is the point at which the proximal and distal axial lines intersect. Center of rotation of angulation. ACA is the angulation correction axis. It is the axis line around which the correction is performed. For this, for mechanical axis deviation, you have to have a long-standing X-ray like this, which can be taken even on non-digital. You can paste 3 cassettes together and take an X-ray, and you can calculate from hip to the ankle. The rule 1 is if osteotomy line and ACA pass through the same cora, bone ends will angulate without translation, either with shortening or with lengthening, depending upon the placement of the hinge. You can see that this is the ACA and the hinge is, there is the cora, hinge is placed over the cora, and you can see gradual opening of the varus side of the bone, and you will get correction of the. And if you put the hinge at the middle, you will have a collapse of the lat cortex on convex side, and you have to remove sufficient weight so that they will not hinder your angulation correction. And if you put the hinge on the concave side, you will have you will have a more wedge has to be removed so that it will not hinder your correction. Initially, you have to do that. If you want shortening, you can go for this type of hinge placement. And if you put the hinge on the ACA away from the convexity, you will get an opening, and also at the same time you will get a lengthening. So you can put the hinge anywhere on the ACA, here or here, depending upon the length you require, so that you can correct the deformity. At the same time, you can get the length if there is an LLD. This is a simple case of a frontal plane deformity. There is no angulation in sagittal plane. There is valgus, and this is the patient, and the deformity is Ilizarov frame has been applied. The hinges are placed on the lateral border. On the convexity, both the hinges are at one place. You can see the deformed frame now. The medial side it is short, the lateral side it is long, and after correction, the hinge has become straight and the rings became parallel, and you can see the beautiful opening on the of the wedge, and you can see the good, beautiful correction. So try to take a simple case like this for the deformity correction at the initial stage and place your rings and place the hinges properly. You can see that the hinges are here still. And another case of simple case of varus, and for the lower end, there is not much of minimal procurement deformity was there, and this is the placement of the hinges, one here and one on the posterior aspect, you can see, and on the lateral aspect, you can see the hinges both are placed at the deformity and gradually corrected. You can see beautiful opening on the medial side, and the rings have become parallel after the correction, and this is the final union. The osteotomy rule 2 says if ACA passes through cora, but the osteotomy does not pass through this, the bone ends will angulate and translate. At the same time, the proximal and distal axial lines will remain in alignment. So the osteotomy is not done here like in rule 1. Here the osteotomy is done at a different level, but the hinge is placed over the ACA. Then also you will get the correction, but there occurs a bump. This you have to take care, because this may give rise to a pressure point if the vessels are now near to that bump. And so assess, and then if necessary remove this bump, and then you can do the correction like this. This situation comes if the hinge is placed at the middle, you will get less bump and more contact you will get. The previous one you have got a less contact, so that you have to add some bone graft there. But here you will get reasonably good amount of contact, and this segment goes into the marrow of this and then fits in it, and union occurs. And the next one, if you put the hinge at the concave side, you will get more contact, much more contact, and less bump here. So this is one where the previously underwent surgery for the supracondylar femur in polio osteotomy was done for hand to knee gait, but this patient went for malunion, and this is the deformity. So the cora has come over here, but I don't want to do this catectomy at that level. I want to do this at a lower level. So I have done a fixator-assisted deformity correction. So initially the fixator was used in the posterior part of the condyle, and then in the femur. The osteotomy was done using this as the cora. This shank pin was put at the cora, and then a dome osteotomy was done below that using a multiple drill holes. And a modified humerus nail has been modified, and then they've taken into this thing and inserted, and the correction was done with the fixator. A nail was inserted, and this is the bump what I was telling. I got this bump on this side, and then the deformity has been corrected, and this is the clinical picture. So something like this also can happen when you want to correct the deformity at the knee, varus knees. So the cora will be near the joint, and you may not be able to do the osteotomy at that level. And if you do the osteotomy below, you will get a correction like this. Here also cora is here, and I have done a oblique osteotomy and got minimal shift, and that has been corrected. In another case, the osteotomy rule 3 is if the ACA does not pass through cora, that is the hinge, and the osteotomy are away from the cora, both are away from the cora, the angulation is corrected, but the proximal and distal axial lines are translated in this. You can see the ACA is here, hinge is not here, but hinge is here, is guided by a set of geometrical principles, and is easy if we follow these principles rigidly. It requires a little more mathematical mind than is required for a science student, biology student. But I think that we can manage if we show some interest. But a simple miscalculation leads to a more profound deformity. So, be careful. I'm showing you a simple example. A boy came with a right femoral deformity like this, and the calculations were done by him, and a fixator was put on him. With this X-ray, I can say that the person, whoever has done this, is not having a knowledge of how to put even a shank pin. He tried to operate on this boy of about 4 or 5 years, and then he has given him, increased his deformity, and the fixator is not sufficient to hold the fragments in position while in distraction, and at the end, that is the deformity which was exaggerated. And when the patient came with this much deformity, we have given him this type of deformity, additional deformity. So, unless you are trained properly, don't go for the deformity correction. This is my advice at the outset. And at present, I am dealing with one segment deformity so that it has been simplified so that you can understand the things well and then start doing the simple deformities initially, not going for the complex deformities. If I tell the whole thing of mechanical axis, deviation and all these things, you will be confused. So go and read in any book. Recently, Dr. Prakash has sent Dreyer Pele's deformity correction in 4 volumes to most of the people, and you can go through. It is a very much pictorial, most of it is diagrams. Just you see and understand, that's all. Not very less of text, and most of it is diagram. You can just go through and you can see the calculation of mechanical axis deviation. Now I am putting you for correction of a single bone with minimal deformity so that you all will start practicing this. I'll give some simple definitions. That is cora. It is the point at which the proximal and distal axial lines intersect. center of rotation of angulation. ACA is the angulation correction axis. It is the axis line around which the correction is performed. For mechanical axis deviation, you have to have a long-standing X-ray like this, which can be taken even on non-digital. You can paste 3 cassettes together and take an X-ray, and you can calculate from hip to the ankle. The rule 1 is if osteotomy line and ACA pass through the same cora, bone ends will angulate without translation, either with shortening or with lengthening, depending upon the placement of the hinge. You can see that this is the ACA and the hinge is, there is the cora, hinge is placed over the cora, and you can see gradual opening of the varus side of the bone, and you will get correction of the, and if you put the hinge at the middle, you will have a collapse of the lat cortex on convex side, and you have to remove sufficient weight so that they will not hinder your angulation correction. And if you put the hinge on the concave side, you will have a more wedge has to be removed so that it will not hinder your correction. Initially you have to do that. If you want shortening, you can go for this type of hinge placement. And if you put the hinge on the ACA away from the convexity, you will get an opening, and also at the same time you will get a lengthening. So you can put the hinge anywhere on the ACA, here or here, depending upon the length you require, so that you can correct the deformity. At the same time, you can get the length if there is an LLD. This is a simple case of a frontal plane deformity. There is no angulation in sagittal plane. There is valgus, and this is the patient, and the deformity is Ilizarov frame has been applied. The hinges are placed on the lateral border. On the lateral border, on the convexity, both the hinges are at one place. You can see the deformed frame now. The medial side it is short, the lateral side is long, and after correction, the hinge has become straight and the rings became parallel, and you can see the beautiful opening on of the wedge, and you can see the good, beautiful correction. So try to take a simple case like this for the deformity correction at the initial stage and place your rings and place the hinges properly. You can see that the hinges are here still. And another case of simple case of varus, and for the lower end, there is not much of minimal procurement and deformity was there, and this is the placement of the hinges, one here and one on the posterior aspect you can see, and on the lateral aspect you can see the hinges both are placed at the deformity and gradually corrected. You can see beautiful opening on the medial side, and the rings have become parallel after the correction, and this is the final union. The osteotomy rule 2 says if ACA passes through cora, but the osteotomy does not pass through this, the bone ends will angulate and translate. At the same time, the proximal and distal axial lines will remain in alignment. So the osteotomy is not done here like in rule 1. Here the osteotomy is done at a different level, but the hinge is placed over the ACA. Then also you will get the correction, but there is, but there occurs a bump. This you have to take care because this may give rise to a pressure point if the vessels are nerves are near to that bump. And so assess and then if necessary remove this bump and then you can do the correction like this. This situation comes if the hinge is placed at the middle, you will get less bump and more contact you will get. The previous one you have got a less contact so that you have to add some bone graft there. But here you will get reasonably good amount of contact and this segment goes into the marrow of this and then fits in it and union occurs. And the next one, if you put the hinge at the concave side, you will get more contact, much more contact and less bump here. So this is one where the previously underwent surgery for the supracondylar femur in polio osteotomy was done for hand to knee gait, but this patient went for malunion and this is the deformity. So the cora has come over here, but I don't want to do this catechotomy at that level. I want to do this at a lower level. So I have done a fixator-assisted deformity correction. So initially the fixator was used in the posterior part of the condyle and then in the femur. The osteotomy was done using this as the cora. This shank pin was put at the cora and then a dome osteotomy was done below that using a multiple drill holes. And a modified humerus nail has been modified and then they've taken into this thing and inserted, and the correction was done with the fixator. A nail was inserted, and this is the bump what I was telling. I got this bump on this side, and then the deformity has been corrected, and this is the clinical picture. So something like this also can happen when you want to correct the deformity at the knee, varus knees. So the cora will be near the joint and you may not be able to do the osteotomy at that level. And if you do the osteotomy below, you will get a correction like this. Here also cora is here and I have done a oblique osteotomy and got minimal shift and that has been corrected. In another case, the osteotomy rule 3 is if the ACA does not pass through cora, that is the hinge, and the osteotomy are away from the cora, both are away from the cora, the angulation is corrected, but the proximal and distal axial lines are translated in this. You can see the ACA is here, hinge is not here, but hinge is here, and then acute docking can be done if it is fresh. If it is old, I don't go more beyond 2 centimeters acute docking, and then because of the vessel kinking, because there will be a lot of scarring of the deep soft tissues which will give rise to kinking of the vessel. But in a fresh case, you can go for about 4 centimeters of acute docking if the vessels are not calcified. If the vessels are calcified, then also you have to go for only 2 centimeters of acute docking and then go for the gradual docking. If the wound is transverse, you will be able to suture it even after 4 centimeters of docking. If the wound is vertical, you may not be able to do that because the dog earring and then protrusion of the soft tissue occurs. And so in that case also you have to go gradually. If the bone loss is between 5 and 10 centimeters, then remove loose fragments, need not to shape the edges now, and catechotomy in the stable segment, the long segment, whatever that is there, and allow the fix the fixator and do the catechotomy and transport. If the bone loss is 10 centimeters or more, frame assembly for double catechotomy has to be made. You can see the double catechotomy. A tandem or tandem type is this. So two catenaries and both travel together towards the docking. And a converging type, one catecatomy here, one catecatomy here, and the bone transport is done converging towards the center. Do not do the fibula osteotomy at this time. Transport
Sir, more science.
Shall I restart?
Yes, sir.
Yes, please.
So, transport till 1 centimeter short of docking. And at that time, you can do the fibula osteotomy and then freshen the edges and correct the rotations at the site of docking if there are any rotational abnormalities, and if there can be a translation deformity also at this time because you have transported the segment for a long distance and there could be some deviation of the transported segment can occur, which can be corrected and docked properly at this time and freshen the edges. And there can be some skin invagination like this. You can see that there is skin invagination like this, and this should be elevated and then docked properly with that. And yesterday something has been missed. That is, the transport should be at a pace of 1 millimeter per day. Yesterday somebody was telling that this has been taught and it should be divided into 4 equal doses, that is 0.25 mg every 6 hours. But don't make him wake up in the middle of the night at 2 o'clock or 3 o'clock for the 6-hour schedule. Otherwise, within 15 days, he'll come and eat your brain. So, my schedule is the first turn will be when he gets up in the morning, and in the afternoon 12 o'clock, and in the evening 6 o'clock, and the last will be just before bed. So that his sleep pattern will not be disturbed and he'll be in good terms with you. Here, that I was telling, correct the angulations, rotation, translation. And one precaution is that do not disturb the regenerate. Whatever that you are doing corrections are to be done at the site of the docking, but not at the distraction site. Because this is the fresh regenerate. If you meddle with it, anything that stops regenerating further or that stops consolidating further. So don't disturb this distraction. Keep it stable and all manipulation should be done at docking. Don't disturb this area at all. You can go for an accelerated docking. If you have done a fibula osteotomy, you can go for an accelerated docking because only 1 centimeter of 1 millimeter of distraction is going on, and this will take a very long time for docking, and so you can go for an accelerated docking so that the union starts at the docking site early, so that most of the times the regenerate consolidates, but the docking site will not get consolidated by the time the regenerate has been consolidated. So that is the one that keeps the frame more number of days. So you can go for an accelerated docking. In cases of intraarticular extension, comminution like this, better stabilize with CC screws or K-wires in the beginning and restore the joint surface. Restoring the joint surface is most important thing for gaining the joint mobility. If this is like this and stabilize it like this, you won't get the joint momented. And once that is done, stabilized, then you assess for the instability of the joint. If there is instability, go for extension of the span the joint by another ring so that the soft tissues are taken care of, the ligaments are taken care of, and after 3 weeks to 6 weeks, depending upon the instability, you can remove the spanning and then add some hinge for mobility of the joint. For doing femur, try to keep the knee in maximum flexion by using suitable table attachment. This is the table attachment that I have. And yesterday also somebody has shown the knee flexion attachment. You can, even if you don't have this, you can hang it and then pin traction or Ilizarov wire fixation and then add a half ring and then use it as a knee flexion device. With implants having infection, remove the implant, wait for at least 3 weeks so that the tracks will be dry, completely dry, and then go for the fixation. Otherwise, even your Ilizarov wire sometimes will get infected. Coming to the cases, trauma with bone loss. This patient had a shattered lower third femur compound. They have operated on him after 3 days with LCP. It got infected. They are taken him to theatre and they removed all loose fragments. Then an infection not under control. So they just have removed this, and at this stage he came to me. There is a big gap. Of course, the joint is restored. So, but he came with a brace. But on X-ray, good X-ray, I could see a flakes of this regenerate forming even on a brace. So I took the gynecologist this thing, watchful normal for a normal delivery. They do this watchful expectancy and masterly inactivity. So I just have applied a frame and watch what will happen. So gradually I haven't done anything, but this started consolidating, and this is the regenerate I have got. I just have put up a frame. I have not done any bone transport. I have not done anything, but regenerate has gradually consolidated and